9 a.m. in Lima, 10 a.m. in the East Coast of the US, and it's the time for us to start our 6th webinar. This is the 6th webinar in the series of the Network for Multidisciplinary Studies in ARV-based HIV prevention. And today we are honored to have Dr. Jessica Haberer to make a presentation on adherence monitoring, state of the science, and future innovations. Before introducing Jessica, I just would like to make an announcement, a short announcement. We recently published the videos, the recordings for the last 2 webinars with Dr. Rick Altis just after Melbourne, and with Valdilia Veloso in Portuguese at the end of August. This is our September webinar. In next month, we are scheduling to have one in French, and we'll announce it as soon as possible. That will be for primarily for a French speaking audience. And in this today we're also recording this webinar. We'll be publishing it soon. If you have any question, you the chat window is open, and please use that. In order to avoid interference, we're going to mute everybody, including myself, after we start with Jessica. So Dr. Haberer's interest in adherence to HIV antiretroviral therapy started while working with the Clinton Foundation in China. She has conducted numerous studies involving multiple measures of ART adherence among children and adults in developing settings. Dr. Haberer joined the Massachusetts General Hospital and the Harvard Medical School in 2008. Her current research involves the study of wireless monitoring technologies and strategies to support adherence in developing settings, as well as adherence to pre-exposure prophylaxis against HIV infection. So again, the title of her presentation is Adherence Monitoring, State of the Science and Future Innovation. So I leave the floor to Dr. Haberer, please.
Okay, thank you very much, Carlos, for the nice introduction. And I hope someone will let me know if you can't hear me. It's always interesting doing these webinars without the audience present. So I'll assume not hearing from anybody means that you can indeed hear me. So thank you very much for the opportunity to speak today. As Carlos said, I'll be talking about adherence monitoring. And let me start going through the slide deck. Oops. There we go. Just to begin, in terms of conflicts of interest, I don't feel I have any, but I want to reveal my funding sources. I am a paid consultant, or have been a paid consultant from IAVI, the WHO, and FHI 360. I do receive funding from NIH and the Gates Foundation, and I do partner with several technology companies, some of which I'll be talking about today, but I receive no financial support from any of them. And I should also mention for those of you on the webinar today, if you were at the IPAC conference, some of the slides I'm presenting are similar to those, so that may be a bit of a review, but hopefully they will be new to most of you. And there is additional material. So as the outline that you see here in front of us, I will start by reviewing some commonly used adherence measures, just to make sure that we're all on the same page with what's available and the pros and cons associated with each of them. I won't be able to go in great depth, but I hope to give you a really good overview of what is available. And then talk about where adherence monitoring is going in the future. So I think there are a bunch of new tools on the horizon, some of which I think have more advantages than others, but we'll go through them. And then I'd like to shift a little bit to think about how we approach adherence monitoring for PrEP specifically, which I think is of most relevance to this group. And then I'll conclude with some recommendations as to what I think should be used when and why. That is, of course, my opinion, but I think it is evidence-based. Okay, so to start with the tools that are available, I think the most commonly used and known tool is self-report. This is a standard assessment that's used in clinical practice, in trials, all kinds of studies, and can really be done in a variety of ways, asking about missed doses, taken doses, how many doses have been missed in a row, using visual approaches like this visual analog scale you see in front of you. There are rating scales which get at more of a gestalt, what is someone's ability to adhere, and then there are frequencies such as how often you take your medications. The recall period tends to be either short at 3 to 7 days or 30 days. And these self-report questions can be asked in person, on the phone. They can be done through the computer. There are really a variety of ways to do this. Sorry. There we go. But as we think about self-report, we have to think about how the mind works and what are we really asking people to do when we ask what seems like a pretty simple question. And if we look at the psychological literature, when people remember something, they tend to remember specific events for a very short period of time, typically a few days, so that 3-day recall period. And the example that I typically talk about is breakfast. We can remember typically what we had today, maybe yesterday and the day before that, but beyond that, we tend to think about patterns. What do I usually have for breakfast? And I think the same goes for medications. So some of those other some of the other approaches I mentioned, like the rating of ability or the frequency of dosing, may actually better get at patterns because we're not asking people to create a number when they really don't remember a number. And Ira Wilson has done some very interesting research with this. I mentioned the reference in the slides. And as he often says, the goal is really to pull people off the ceiling. So if somebody's reporting anything less than 100% adherence, I think that's useful information in identifying someone who might be struggling. So with self-reported adherence, the pros are that it's very easy to collect, it's inexpensive. People can use whatever aids they want in terms of taking their pills, like pill boxes. But the cons are inaccuracy. People tend to want to tell us they're doing well, whether they are fearful that they might lose their medication or have some other consequence, or they simply just want to please, which is often human nature. Also, this data tends to be collected infrequently at clinic visits or study visits, and people just honestly may not remember what they forgot, or they may have trouble remembering what they did do. So that recall bias is definitely an issue. Differential response bias is common as well. People don't always understand what we're trying to get at. It may seem straightforward to us as researchers because this is what we do, but people don't always think about exactly how many pills they've taken on what days. And then getting the patterns of adherence is difficult. We can ask people, but again, we're asking people to remember things they don't typically remember. So moving on to pill counts, this is a adherence measure that can be done, again, in many different ways. The most common is announced at clinic, pharmacy, or study visits. Studies commonly have people bring their pill bottles with them. And then just simply count them when they come back. And you can see the calculation on the slide. We take the pills dispensed minus the pills counted and divide it by how many pills they should have taken during that period, the pills per day by the number of days. And these can also be done unannounced, where you show up at someone's home. And that adds a layer of objectivity to it. Or this could be done over the phone as well, with an unannounced phone call. As you see on the next slide here, the pros are that pill counts are relatively easy to collect. People are there. They typically will bring their pill bottles with them if you ask, but not always. It's an inexpensive measure, and people can use whatever kind of aids that they want, similar to the self-report. But the main concern that I have with this measure is that social desirability is still a problem. People know if the pill counts are done in an announced way, they know you're going to do that, and they may end up in the trash can outside the clinic. So pill dumping is definitely a concern. Less so with the unannounced, although people can dump pretty quickly. And there are no patterns with this measure. You just get a summary. So again, it's hard to know if people have taken major gaps in their adherence or just missed a few here and there. And then the potential for the Hawthorne effect, because people know that they are being observed, and that may lead to the pill dumping that I mentioned before. I think I've covered most of this. So with the unannounced pill counts, they do tend to be a bit more objective, but they are much more difficult to do. Showing up in somebody's home unannounced means that you have to travel and that you have to find the person there. So they do tend to take a lot more resources, although they are feasible, and we certainly have used them in multiple studies. So the next category I'd like to review is pharmacy refill. And this is really the percent of medication possession. You can see it listed here on the slide as the medication possession ratio. And that can be calculated basically as the number of days or months that drug is dispensed over the number of days or months between the first and last dispensing. So you know somebody has the medication available to them a certain percent of the time. It doesn't tell you if somebody's actually taking it, but you know that the medication is available to them. So it may be an upper limit, like a higher estimate of their adherence, but it actually has been shown to perform quite well with treatment. And there was a nice paper by Bassan a few years ago showing the ROC curve that you see on the slide, and indicating that pharmacy refill, which is in the green right here, was better than CD4, which is in the orange here, in terms of predicting viral suppression. So even though it's a fairly blunt measure, it does have some attractive features. It is inexpensive typically. It's certainly feasible in resource limited settings, as long as you have a controlled pharmacy where you have good records, especially if they're computerized. That's very helpful. People can do whatever they want with their pills, again, in terms of the reminders and other types of aids that they may be using. But the logistics of tracking pharmacy refill really need to be thought out well. Often different pharmacists may be involved with any individual in your study. And if not everybody is aware that you want to track how many medicines are going out and how many are coming back, they may adjust medications for people here and there without recording that. And we've certainly seen that in our studies. So even though it is a fairly straightforward measure, and I think it does have a lot of utility, it has to be done very purposefully, and making sure that everyone who's involved with the pharmacy is aware and that all the records are available. If people are using multiple pharmacies, it's going to be very difficult to track when they're picking up medications from which pharmacy. Okay, the next category are electronic monitors, and specifically the Medication Event Monitoring System, or the MEMS-CAP. I think a lot of us are familiar with this one. It's been used in hundreds of studies for over 25 years. And basically these pill bottles create a time and date stamp for each opening and closure based on a plunger inside the cap. A microchip records that opening, and then the data can be downloaded through a USB cable. And here on the left, you can see a participant with twice daily dosing. These are the morning doses on the bottom and the afternoon doses on the top. And you can see that this participant has been doing quite well. And then looking at the figure on the right, you can see that there are problems here where there have been gaps. So this information is really useful in understanding what the day-to-day behavior is like for pill taking. So it's likely our most objective measure of behavior. It provides patterns of adherence, unlike almost every other measure of adherence. But there are downsides to it. People sometimes will open the devices without actually taking any medication, or they may take out multiple pills at a time and put them in their pocket or some other container that may be more convenient or potentially less stigmatizing, depending on the individual and their circumstances. It does require adherence to the adherence measurement, and that people do need to use this pill bottle. And so that is a potential limitation. And people may change their behavior because they know that you are monitoring every opening. Studies have looked at the duration of the Hawthorne effect with MEMS caps, and it appears to be fairly short-lived, somewhere around the 6 to 8 week mark. People tend to go back into their regular routines and get tired of trying to alter what they normally do, but that potential is definitely there. Electronic monitoring is expensive. The MEMS caps I don't I don't know the latest figure, but somewhere around $150 each. And there are other monitoring devices like this that are roughly in the same ballpark. And people do have to use this specific bottle. They cannot use pill boxes and use this adherence measurement. So next I'd like to switch to drug levels. These can be performed in a variety of ways, most commonly in plasma. Peripheral blood mononuclear cells are another option, but that requires more laboratory processing. Plasma is useful for about a 2 to 3 day window for tenofovir, for instance. It's variable by each drug and what the half-life is. The PBMCs tend to give a longer view of what the pill-taking behavior has been. And similarly with dried blood spots, looking at whole blood, that's another way to get a longer-term view of someone's adherence behavior. I'll come back to hair in a minute. But these are very attractive in that they provide an objective measure. It is a summary measure of how well someone's been doing with their adherence during the window that corresponds to the technique you're using. Again, usually in the order of days for plasma and perhaps weeks for PBMC. Looking at this slide here, as I mentioned, they are objective. It does mark actual ingestion, unlike any of the other measures we've talked about. And it can be very useful in distinguishing people who tend to adhere and people who tend not to adhere. Deborah Donnell published a nice paper about that from the Partners PrEP study. But the cons are listed here as well. The potential for Hawthorne effects is present with drug levels like the other measurements. If people know that they're going to have their blood drawn, they probably take their pills, maybe a little bit more than they would otherwise. This is expensive. Even if you batch the testing, each test tends to cost somewhere around $50, $75, depending on how you're doing it. It requires specialized lab capacity. The dry blood spots are nice because you can store them easily and ship to one lab, so that does reduce the number of facilities you need, but you still do need that specialization. And then the major downside I see with drug levels is that they're subject to both biologic and behavioral variation. So there may be differences in metabolism, there may be differences in dosing, and it's pretty much impossible to distinguish those, although you can get expected ranges based on the metabolism from population pharmacokinetic studies. And one paper done by Cheryl Lichty several years ago looked at unannounced one-time drug levels to see if you could distinguish adherence that way. And it did confirm more or less what was seen in the Donnell paper, in that if somebody was really challenged with their adherence and had adherence on average less than 60% by electronic monitoring, you could detect that with a one-time sample. But getting at finer gradation of adherence, it was really difficult to do. So looking also at viral load, this is obviously for treatment, not for prevention. That's another way that a lot of people look at adherence. It is objective, and it indicates that somebody is adhering well enough to suppress the virus. It is expensive. Typically those tests run around $60 to $75. And they are typically done infrequently because they are logistically difficult to do in a lot of places. And the other problem is that they don't reveal any adherence challenges that may ultimately lead to virologic failure. So as I said before, it does tell you that there is adequate adherence, but it doesn't give you any warning, and the horse has kind of left the barn at the point that the viral load is detectable. So that concludes my summary of what we can do, or what we do currently for most adherence measurement. And now I'm going to switch gears to look at kind of the future and what are some of the emerging approaches to adherence. Some are being used more commonly than others, but I think these are all definitely in the emerging category. So the first one is using cell phones to measure adherence. As you can see in this figure here on the left, this is the number of cell phone subscriptions globally. And this data is a little bit old, but looking up through 2008, you can see a steady increase. And what's really exciting in this figure is that the legend here is in billions. So one of the few tools we have that that is accessible by 4 billion or more people, I think we're up to probably close to 6 billion, if we had more recent data. And the number in developing countries is growing faster than developed countries. So that's also very exciting. And as you can see here in this figure, this map of Uganda, this is from one of the cellular networks, and everywhere that you see the orange color has cell phone reception. So while it's not covering the entire country, you can see that it's covering a very large percentage of it. And so you have these tools that are nearly ubiquitous. And here you can see a couple of people who work on a study with me training on how to use cell phones for adherence measurement. So the pros of using cell phones, you can use both texting or SMS as well as interactive voice response. And that's the interactive voice response is a really nice option for people who are not literate. Basically, the cell phone has a recorded message that can be responded to with a touchpad number, but it doesn't require any actual reading. It does require the ability to use the phone well and to understand what we're asking people to do. But having both texting and verbal options is definitely a pro. Cell phones are convenient. We all have them with us pretty much all the time. So frequent data collection is possible. And there's relative anonymity. So some of that social desirability that I mentioned before with self-report may be reduced because people are not as worried about mentioning that they're having trouble when it's a computer as opposed to an individual. But there are definitely cons. I think everybody knows the Verizon guy down here in the corner. So you can't always get people when you want to get them, and that creates some difficulties when understanding missing data. There is potential for variable understanding of expected responses. As I was hinting before, there's a certain amount of literacy involved with using technology, not the traditional literacy, but more of a technology literacy or tech savviness. And I think that's improving as more and more people use cell phones for a variety of reasons, but we've certainly seen difficulty with that in earlier studies. I mentioned the literacy issue. People do tend to share cell phones, especially in developing settings. People don't always keep their phones charged and on. They may not be available when you're asking them for the information. And there is a certain amount of cost associated with setting up these systems, although once you have them up and running, the cost of each individual survey, whether by text or IVR, is generally quite cheap. So in terms of feasibility, like how easy is this to really carry out? You know, in one study I was involved with the IAVI group, we looked at response rates for daily SMS to PrEP, adherence to PrEP, and sexual behavior. And we were able to get about 74% of our queries, responses to about 74% of our queries from serodiscordant couples in Uganda, but only about a quarter of the surveys were responded to successfully by the MSM and female sex worker population we studied in Kenya. So there are a variety of reasons for this. Some of them are technological, in that we had some outages and difficulties with the cell phone providers, more in Kenya than in Uganda. But also different populations may have different circumstances in terms of their ability to answer questions whenever they were sent. So it's definitely feasible, but there is some variability there. And in a more recent study, the IAVI study was done in 2009 and 2010, but in a study that's going on right now in the Partners Demonstration Project, where we're looking at PrEP adherence in serodiscordant couples, also in Uganda and Kenya, we're seeing very high rates, 75% on average, and that data was presented at IPAC, both looking at PrEP adherence and sexual behavior. And you know, as I mentioned before, we did have some trouble with studies like this several years ago, and I think one of the reasons that we're doing better now is that we're providing training as people need it. So because we're getting this information very frequently, we're able to find out when people don't understand pretty much as they're providing the information, so we can call them back and provide the training on how to respond or troubleshoot any technical problems more or less in real time. the understanding how people use their phones has been very useful in that training process as well. So this seems to be feasible, but something that should be undertaken very purposefully, and not just assume that people will be able to respond to surveys simply because you've sent them. So I'll switch now to wireless electronic adherence monitors. You can see a variety of them on the screen. The one that I have circled here is called WisePill, and that's the one I work with. By no means is it the only one, and I don't want to appear biased because I think many of the things I'm about to show you would apply to these other devices as well. So this, like cell phones, provides more or less real-time data. The WisePill device here that you can see on the left communicates directly to a server. It functions very much like the MEMS cap in that it records a time and date stamp every time it's opened. But instead of having to download that data with the USB port, it goes pretty much immediately to the server, and that information is then available on any laptop anywhere, or it can be sent back to the individual or to anybody else through a cell phone. So that information is very readily available to pretty much whoever you'd like to send it to. And this figure on the right here is the data display, very similar to the MEMS cap, with the time on the y-axis and the dates on the x-axis, and each dot showing an opening. And I just like to point out here, I downloaded this data yesterday on the 22nd. So we could get an individual's dosing really that day, and this data came from rural Uganda. So it's very exciting to be able to understand what people are doing, even if they're thousands and thousands of miles away. So does this work well? You know, that's, I think, a great question for any kind of adherence measure. And there's no gold standard, but in comparing it to viral suppression, this is a study that we did in people on ART a few years ago. The WisePill adherence is shown in these gray bars here, average adherence on the x-axis and percent of people with viral suppression on the y-axis. You can see a pretty good distribution of adherence. We also looked at IVR and SMS weekly queries, and those are shown here in these striped bars. They were very much clustered at the top of the adherence range. And we basically found that loss of viral suppression was associated significantly with the WisePill data, again here in the gray, but not with the IVR and SMS report in the striped bars on the right. So the self-report did not seem to perform very well, but we felt comfortable that we were getting good data with the WisePill. So another issue with any new technology is whether or not it's acceptable and how much it may change behavior. WisePill is currently being used in quite a few studies, and we've found generally high acceptability in Uganda, where most of my work is done. There was a similar study with a similar device, I should say, in South Africa called the Wise Bag, which is basically the same device but put into a container that looks a lot like a lunchbox that could be used for applicators for a microbicide trial. And with an exploratory study, Ariane van der Straten found high acceptability as well. However, in another population in China, which was IDU, they did not find as much acceptability. So I think these issues need to be explored with different populations. But at least in the work that I've been doing, we've had very high acceptability. And in fact, people are very disappointed when we don't let them have it because of some logistical reason, like living too far away from our clinic site. And then in terms of the Hawthorne effect, I think it's real, and I think it's probably more of an issue with WisePill than it is with MEMS caps, because people know that you're watching them every day. It's not something that just gets downloaded at a periodic visit. And that can be an advantage when you're looking at intervention, but it can also be an issue if you're looking at monitoring. And with one of the other devices called MedSignals, they studied this a few years ago and did see that simply using the device increased adherence, so that the monitoring itself was really an intervention. So what are the pros and cons with these electronic adherence monitors? Basically everything that I mentioned with MEMS, plus the capacity for real-time data and intervention. that's really powerful in terms of being able to do that just-in-time intervention, but also for reducing data loss if you have a population that doesn't always return for visits as planned. And another pro, which I forgot to put up here, was if you're using, if you're working in an area and using remote sites and you don't have a large staff, the wireless devices are a really good way to extend your human resources. There's a group at University of Alabama who's doing this, and I think it's been very useful for them to get out into remote areas and not have to keep sending people, but to use the devices to collect that data independently. But the cons, they are expensive. They're about $185 a device for the Wise pill. I think the other devices are pretty similar, although I think those costs will be coming down as volume of use goes up. There's increased data management needs. You really have to have somebody acting on real-time data in real time if you want to get the benefits from it. You do need to have cellular reception. A lot of the issues I mentioned with the cell phones, these apply to these devices. They're essentially cell phones in that they have batteries and SIM cards. There's also potential for unintended disclosure because these devices are unique and may elicit questions from neighbors and family. So that's something that we always mention in our studies and our consent forms. And I already talked about the Hawthorne effect. So the next category I'd like to go through are ingestion event monitors. You can see a variety of them listed here, or shown here on the slide, and I'll go through them briefly. So the first one are edible tracers. There are three of them: the Helios, IntelliCap, and MagnaTrace. I think Helios is the most developed. This is put out by a group called Proteus. And you can see in the figure up here on the right how it works. Basically, there's a very, very small microchip that is attached to each pill. And as that microchip is swallowed and interacts with the acid in the stomach, it releases a signal that then gets sent to a patch that the individual wears. And this patch will then record that the medication was ingested. And it also can record heart rate, temperature, and activity, so providing quite a bit of information about the individual. The studies that have been done so far suggest that it's very sensitive and specific when compared to directly observed therapy. So it really seems to be working technically. And the feasibility and initial acceptability seems to be good in small trials. There was one with individuals who have mental health disorders in the US, and another with TB treatment, but again, very small numbers, but it initially does appear to work well. The next group are Taggants. So these are drugs that are marked with an ERT detectable metabolite, basically. And this one I'm showing you here is called Exhale, and adherence is measured through breath. So a reminder is sent to an individual to breathe into a device periodically, typically every day, or could be as often as you like. And the medication, as it's processed in the body, releases that metabolite, and when they breathe out the tube, it should be detected. That information is then downloaded onto USB and can be managed much like the electronic monitoring data I mentioned earlier. The only study I was able to find assessing this was with a different approach to Taggants than with the Exhale group. This was looking at an ester Taggant for a vaginal gel, but it's just the same idea, and it did seem to be feasible in a very small study. So another way to detect metabolites is through the urine. There's a group out of MIT. It used to be called XOUT-TB, and now it's called Adhere.io. And this was used primarily with TB treatment, as you can imagine by the name, but it could be applied to other medications, like for HIV prevention. And they labeled this a behavioral diagnostic. Essentially, the individual takes the medication and then urinates on one of these sticks you can see in the figure here. And then a code is revealed that can be text back into a central server, and people can be given rewards or incentives for going through this procedure to document adherence. This was evaluated in Pakistan, although I never saw a publication presenting those results. I do know that there was a trial going on at least a year or two ago. And then another approach is to use cell phones in a different way, to actually, instead of asking people what their behavior is, to actually document it visually. And there's a group called AI Cure who's doing this. And you can see in the figure, this is meant to show multiple steps, but an individual turns on the phone, opens an app, shows the pill to the camera, and then the camera documents as they ingest the pill. So this is a visual recognition, and they have quite sophisticated software to try and make sure that people are actually swallowing it and not trying to fool the camera. It doesn't require a special medication container. You can use whatever you like, or a specific device. It's really just taking a picture of yourself as you swallow the pill. But I did not see any publications from that group. So in summary, with these ingestion event monitors, it is really attractive that they can document ingestion. They can show patterns of adherence, much like the other electronic data I showed you before. And it can be available in real time for most of them. Some of them still are downloaded. But the cons is that it requires adherence to an adherence monitor or adherence monitoring strategy. Even with the cell phones, even though you're not using a specific device, you do actually have to pull out the cell phone every time you want to take a measurement. And I personally am a little bit skeptical of that kind of approach. I think that people tend to do what they tend to do, and when you ask them to do something that they don't tend to do, they probably won't do it for very long. But that could be addressed through incentives. You know, people use cell phones all the time for all kinds of things, so it's possible that people would be willing to do that as well, but we just need to see more data. And there are also some ethical issues, especially when you're looking at swallowing things like microchips. Some of the other devices I didn't go through in detail use like radio frequency and other things that people may be uncomfortable with. And so I think ethical studies are necessary. The logistics of repackaging or using secondary pills, sometimes these secondary pills are needed for the actual tracer, like with the edible monitors. That can be difficult, and I think it's a little bit clunky in terms of getting people to use that in day-to-day life. So I think there's promise with these event monitors, but they're still definitely under development. And then finally, actually, I have two more. So, but the last one on these innovative devices is Google Glass. So I have not actually heard Google proposing to do this, but Google Glass is coming, where we can see what people do throughout their day. So you could imagine this is another way of visually documenting adherence behavior. So the final innovation that I'll go through are drug levels in hair. And this is becoming more common. Monica Gandhi's group out of UCSF is a leader in this area and has shown that the drug levels in hair have surpassed any other prediction of viral outcomes in the WISE study. As an example, the atazanavir levels in the highest quartile had an odds ratio of nearly 60 in predicting virologic outcomes, which is really quite impressive. Al Liu published a nice phase 1 pharmacokinetic study showing a 76% increase in hair level per twofold dose increase in the frequency of dosing. So these appear to be quite accurate. And acceptability has been high in most studies, although when I tried to do this with a pediatric population in Uganda and ran into a lot of trouble with acceptability. And I think there was also some trouble in South Africa. So some people feel very strongly about hair for a variety of reasons. So it's, I think, largely acceptable, but not universally. So some of the pros of using drug levels in hair, it's very simple to collect. It doesn't require needles, and it can be stored at room temperature. It can be processed centrally. It gives a nice summary of how people have been doing over time. So kind of somewhat of a qualitative look, yes or no, have people been taking their drugs? But there are costs associated with that processing. You do not get the patterns that you get with the day-to-day measurement of electronic devices. The same issues of metabolism still apply with hair as they do with the plasma or blood, other types of blood samples. And then I mentioned that there may be some challenges with sample collection and acceptability in certain populations. Okay, so I think this is my third shift in the talk to talk about a framework for PrEP adherence, because I think innovations in adherence monitoring also have to think about the differences in what we're trying to measure. And prevention is different in a lot of ways than treatment. With adherence to antiretroviral therapy, the expectation is daily pill taking for life. And when we're looking at PrEP, I think that we need to think about a new paradigm for that. Because with adherence for PrEP, we're talking about daily pill taking when someone is at risk and relying on PrEP for protection. And daily may change as we get into different regimens, but for now, the studies have really focused on daily pills. And I'm not talking about microbicides here as much, but I think some of these same ideas will apply as well. And so thinking about this a little bit more, daily adherence during periods of abstinence that would be, if we were looking at this at adherence to the old lens or the lens that we use with treatment, daily adherence is always a good thing. But if you're taking medication daily in a period when you're not at risk, like abstinence from sexual exposure, you're basically exposing people to side effects and costs without any prevention benefit. So is that really what we're looking for? And then the converse, if somebody is periodically adherent, which for treatment would be a bad thing, if somebody's only at risk during certain periods, but those are the periods where they're highly adherent, that may actually be a very effective way to approach adherence. So several of us at the WHO and some others have been in this field have been talking about a new type of adherence or framework for adherence that we're calling prevention effective adherence. And this requires understanding pill-taking behavior plus the concept I was getting at earlier about periods of risk. What are people's behavior? What are the other prevention tools they're using during those periods of risk? And then how are they taking their PrEP? When are they starting? When are they stopping? And all of this really needs to be factored into the overall concept of adherence. And to make it a little bit more concrete, you can think about contraception. Adherence, effective contraception can be achieved in many different ways. It can be through adherence to condoms. It could be adherence to oral contraceptive pills or patches or depot injections. And adherence to one method only all the time is not really the goal. It's really finding a method that works for an individual, and that individual may cycle through many different options. So thinking a little bit more about each of these categories, with periods of risk, understanding their behavior, we're talking about people's sexual activity with partners of unknown or positive HIV status, and or injection drug use. Now, how do we measure that? Getting back to the overall concept of measuring adherence, these are difficult to measure. We're largely limited to self-report. You can potentially improve on self-report with short recall periods, like I was describing with SMS surveys earlier. People may remember their sexual activity in the previous 24 hours better than they could over a 30-day period, for instance. You can get biologic markers for sexual activity. For instance, you can look at PSA in the female. Or male if you're looking at an MSM population. Or with drug use, you could look for drug levels, but these are difficult to obtain, and it's certainly in an implementation setting, although it could be part of a study protocol. And another thing to remember as well is that estimates of risk are difficult for people. They don't always know when they're at risk, or their risk may change very quickly. And Amy Cornelli published a nice paper on this earlier this year from the FemPrep study. So I think we have to do a lot more research to understand risk, understand how to measure risk, but I think this is a really important area because it does really impact what is going to be an effective adherence pattern. And then the other side of this period of risk is what else are people doing to protect themselves? Again, if people are not using anything else, high PrEP adherence is the goal. But if they're using condoms or their partner is on effective ART, they've reduced their number of partners or their type of partners. All these things may change how we think about the effectiveness of their adherence. But the main point I want to make here is that they all do require measurement. We can't just have a study of PrEP where we measure PrEP alone. We need to think about all these other things as well. And that use changes over time. So people may use condoms with one partner in a certain time period, but maybe not with another at another time period. Or their partner may be on treatment, or they may not. And so measuring it over time, just as we do with PrEP, will be really important for fully understanding what their prevention effective adherence is. And then thinking about when people take PrEP during periods of risk. So I wanted to digress just a little bit and talk about the difference between periodic and intermittent PrEP. The term periodic use here is really referring to seasons of PrEP, which Nellie Mugo coined. And that's really referring to these times in people's lives when they want to take PrEP. Again, going back to the comparison with treatment, treatment is for life, but PrEP is generally not for life for most people. So most people will be going in and out of periods when they need to use PrEP. And our recommendations for how to do that well, I think, are still emerging. What we're seeing right now in most guidelines and in most expert panels is to initiate a week before we can, daily dosing for a week before we consider it effective. And the discontinuation after a potential exposure, the only literature we have to go on are from the post-exposure prophylaxis studies. And those suggest 28 days, but that was based on basically one study. So we really don't know what to tell people, but I think that's kind of the recommendation at this point. And understanding the intentionality of starting and stopping, I think, is another area that we're going to have to explore. I'm not sure how well people do this and how well we can capture it, which I'll get to in just a moment. But I wanted to distinguish periodic use from intermittent use. And so intermittent use in reference to daily dosing, I'm not talking about the IAVI study or the IPER-GAY study, where people are using PrEP on a prescribed intermittent basis. I think that's a different discussion. But intermittent use in this context would just be missed dosing and is not something that's currently recommended by any of the guidelines. So how do we measure when people start and stop a period of use? Again, self-report is challenging, especially when you're looking at something that's likely to take place over long periods. People may have a few months, for instance, where they are engaged in sex work, and then a few months when they're not. And for them to say that started on May 3rd and ended on August 11th is I think, unrealistic. We may be able to improve on these reports with more frequent questions, like, again, with the SMS surveys for shorter recall periods. But I think it's difficult for people to do that well. Pharmacy refill is another way to look at how often people are picking up their PrEP. And so if they picked it up, that they could take it. And if they didn't pick it up, they couldn't, although they may have held on to some pills from an earlier prescription. So pharmacy is one way to do it, but discontinuations may occur and will likely occur before all the pills have been taken. And there may be times when people start and stop within a single refill period if that period is multiple months in length, as many of them are. So it's not perfect, but it's one way to get at it. Electronic monitoring, similarly, will give you an idea of when people are taking it and when they're not, but that intentionality may not be apparent. So it's hard to distinguish when someone actually decided that their season of PrEP was over. So it may be that a combination of these methods can give us the best estimate possible. And then to think a little bit more about these ideas, how do we use them when we're determining what adherence is? I wanted to get into two concepts. One is execution and the other is persistence. So the execution of prevention effective adherence, I'd like to consider what goes into the numerator and denominator of the equation that you see here. So when determining execution, we're trying to understand the number of doses either reported or observed, depending on which measure you use, divided by the number of expected dosing events. So this is really the execution of adherence when people are taking PrEP. And in the numerator, you can get that however, whichever way you want to, based on all the different measures I talked about earlier, ideally through an objective measurement. But with the denominator, we have to consider those periods of risk, the initiation, discontinuation of PrEP that I was talking about. Because with ART, that denominator has always just been the period of study. But with PrEP, that may not be the case. People may come in and out. They may not be at risk. And the value of that adherence information really depends on those choices and those behaviors. Again, a perfect adherence with no risk isn't really telling us what's effective. Or low adherence, but confined to the periods of high risk may actually be what we're looking for in terms of most efficient use of resources, as well as limiting side effects and other potential adverse events. And so with persistence of prevention effective adherence, this is really the duration of pill use or of taking PrEP. Going back again to ART, the expectation is that persistence will be lifelong. Once someone starts therapy, they should always be taking it. But with PrEP, again, we have to think about how long they should be persisting. Persisting for life is probably not a good idea for most people. So how long do we want them to persist? And I think that time frame needs to be included when we think about persistence, because a persistence of 3 months may be really an ideal goal for one individual, whereas it may be very, very limited for somebody who should be on it for much longer based on their periods of risk. So I will shift now to my final area, which are my recommendations. So I think there are many factors that go into which measurement tool you should use, and it can be summarized by what your resources are and what your goals are. There's a very nice paper by Ann Williams, I think that was circulated for most of you, looking at ease of use, expense, capacity, goals of measurement. So I encourage you to read through that to kind of help think about which measure makes sense for your particular study or project. In general, I can say that I think self-report is too unreliable to be the only measure. That's not to say that there's no value in it, but I would not hang my hat on any study with only self-report. And on the converse, a lot of people are kind of leaning towards using drug levels or viral load in treatment studies as the only adherence measure. And I don't think that's the way to go either, because it really doesn't give you much information about behavior. With drug levels, you're really limited to the range of the assay, so a couple of days to a couple of weeks. Without those patterns of adherence, that can be very important, especially as we think about prevention effective adherence. And with treatment, you're getting, again, enough adherence, but you really don't know about problems until they're quite significant. So my recommendation is really to use multiple measures, including at least one objective measure when possible. And I often get the question, I have no money, but I really want to know about adherence, so what should I do? So in studies where people are very constrained by resources, I would recommend pharmacy refill. Again, if it's a closed system and you're actually able to track where medications are going, that is the most objective and least expensive if you want to combine both those criteria. But I would also consider reprioritizing funds. Adherence is, I think, well, for those of you who are on the webinar, you obviously think it's important or you wouldn't be here. But I think a lot of people have underestimated the importance of adherence in trials. And I think we've seen through a lot of the experience with PrEP, it really is a key feature and shouldn't necessarily be an add-on, but more of a core component to the study. And if you cannot do objective measures in the entire population, that's not necessarily a problem. You can look at a subset, you would have to do your sample size and sample selection strategy carefully. In terms of pill counts, I think those are generally similar to self-report, so I don't tend to recommend those beyond self-report. And then for real-time monitoring, I think it makes sense when you need the data in real time, or if you're in one of those situations like with that study in Alabama where they need to be out in a widely dispersed geographic area, or you are worried about data loss. And with the ingestion event monitors, I don't think they're quite ready for prime time, but they may be viable tools for use in the future. So my final recommendations are about PrEP specifically. And I think we need to think about the three different studies that have been going on and will be going on. The first is with clinical trials, and I think drug levels are very useful in that setting, because you're really not trying to get at what are people doing in day-to-day life. You really just want to know, are people taking this drug or not? And so if you have periods where you have documented ingestion or no evidence of ingestion, that can give you a lot of information about your ability to estimate efficacy or to determine efficacy. I think electronic monitors are incredibly valuable. In clinical trials, the resources tend to be more plentiful. So I think it's worth investing in that, at least in a subset. And if that's not possible, definitely looking at pharmacy refill to try and fill in some of those gaps between the drug levels. With the demonstration projects, I still would advocate for at least one objective measure. Some demonstration projects tend to be more on the side of implementation, and some tend to be more on the science side of things. I mean, they're both science, but more of a trial sort of mentality. So you may end up favoring electronic monitors in that context and more pharmacy refill in the other. But I would recommend storing blood occasionally for selective drug levels so that you can always go back and try and get a better understanding of how often people were taking medication at certain periods. And then to pair those measures with self-report to potentially identify useful measures when you get to implementation. And that's the only tool that you may have. And again, measuring periods of risk and initiation and discontinuation of PrEP. And I think I'm almost out of time, but I have one more slide. And that's an implementation. I would recommend using optimized self-reports. So ideally, these measures that were explored through the demonstration projects and hopefully shown to work in a specific population. That's work we're doing right now and hope to publish soon from the Partners PrEP group. And storing blood samples when you can, and again, paying attention to periods of risk and when people actually choose to start and stop PrEP. So these, very briefly, are my acknowledgments of all the people who've helped me understand these issues, especially with prevention, effective adherence, and my funders. So thank you very much for your attention.
Jessica, thank you. I think it has been a wonderful, a very useful presentation, a very useful summary, and we're really glad you were able to present it, particularly to so clearly show the difference between adherence to treatment and adherence to PrEP. And so definitely the concepts you have raised regarding what means to adhere to PrEP and how dependent it is on actual risk is very useful. Definitely many people think of PrEP still as something that people have to take for life, just as treatment, and it's obviously it generates a lot of concern because they think of side effects and many other things, and clearly there are differences with regard to, for example, switching from one method to another, which people can do, or obviously ending a period of higher risk. And I mean, this is actually people are doing by themselves. They are not going to ask for permission for that. We just have to figure out what's happening there. So I wonder if you think there are already clear guidelines for people telling them this. If for any reason you have stopped taking PrEP, and well, you don't need. We know that you don't need to take it every single day to be protected. No, you need to take it 4 or 5 times a week. But probably it would be useful to be able to tell people you need. I mean, if you haven't taken your pills in the past X days, then you are not protected, and you should use. If you're at risk today, you should use something else. You should use a condom, or yeah, when you intend to enter uh, uh, sexual activity again, and that sexual activity might pose risk, then you should start taking your pills at X days before. Do you think it has already been discussed and in order to provide counseling?
Yeah, I think it's certainly under discussion, but I think I don't think any guideline is ever going to say to not use condoms all the time.
Right.
I think that there's reality and then there's what's going to appear in the guidelines. Is I think with with condoms, there are obviously other things that are protected, like other types of infections or pregnancy in heterosexual relationships. So I think the condom recommendation will always be there, but I think the emphasis needs to be there that if you have not been taking daily PrEP when you're relying on it as your primary HIV prevention tool, that you really need to think more about your risk during those events, and it's even more important to be using condoms or some other strategy. Make sure that your partner is taking their ART so you're not worried about a high viral load, that kind of thing. So I think it's a more nuanced discussion, and it's easier just to say always use condoms and always take your pills. But I think we're recognizing how unrealistic that is, and it's really a disservice to the people we're trying to support. So I hope that the guidelines will evolve. I know personally, I'm working on an opinion piece about these issues that I hope to get out fairly soon, that I think will help generate discussion about this. But I think it'll be a while before this kind of approach gets into the official guidelines.
Okay, great. You're completely right, but at the same time, we know that people who are most adherent to PrEP are those who have more problems with condom use, and it makes sense.
Yes.
Definitely, yeah. So I guess, well, at some point, no, we people, educators should be able to feel that they don't need to be politically correct all the time, and yeah, to
Yeah,
be more realistic about what happens with people in real life, and
right.
it's not casual that actually people who are most adherent uh, to PrEP in demonstration studies are those who have more problems using condoms, and yeah, and feel they are at risk, no, that kind of thing.
Right.
But anyway, there was one question from Juan
Yeah.
asking if there are examples about cell phone technology in Latin America, and particularly smartphones. Hmm.
Yeah, I haven't done any work myself in Latin America with cell phones, but I do remember some, I'm blanking on the name, but there were some studies in Peru a few years ago, and I can send them around to the group later when I've had a chance to look through my computer. But looking at the use of cell phones for reporting behaviors, I think they were HIV related. And then in terms of smartphone use, I have not personally used smartphones that much. I've tended to stick with the feature phones just because of wider availability. Although the smartphone penetration is rapidly increasing, even in very resource limited settings. So I think smartphones are definitely worthwhile in terms of exploring different educational or measurement strategies. But I personally have stuck with the feature phones.
Okay, and one last thing, I wonder if people are starting to discuss the concept of adherence to prevention and not to one particular prevention method or strategy. You know, so to assess whether one particular person in their own life circumstances uh, is covered by either PrEP or condoms or just non penetrative sex or sex with a person with known sort of status seroconcordant. No, so I think that kind of reasoning. Are you aware?
Of anybody studying that?
Oh, I mean, if it has been discussed as a strategy to switch from a logic of adherence to PrEP, for example, to a logic of being covered, because that's exactly the equivalent to what you're saying. I mean, when somebody sort of stops PrEP, maybe that person is not being exposed, or that person is only having sex with a partner of known HIV status. So I think I mean, from that person's logic, that person is being covered by prevention, by prevention strategy. You know, it's just that it's not PrEP right now, that kind of thing.
Right, yeah, I don't know of anybody who's doing that outside of the groups that I'm working with. In the Partners Demonstration Project, we are measuring a lot of these things. You know, the initial approach was to measure PrEP, but I think, you know, over the last couple of years, we've recognized the importance of a broader definition, this prevention effective adherence. So when we present our results, we're going to emphasize both approaches. So it, you know, understanding what's going on with PrEP specifically, so we can get an idea of how well people are taking it, but then to take into context the larger issue of what is really required for people, and as long as they are protected somehow, that's really our goal. And I think that needs to be more a part of the conversation for these demonstration and implementation projects.
Okay, Jessica, I think we have to end now. It has been very interesting, really. Thank you very much for being with us today. We'll sort of edit and publish this session very soon and let you know. So thank you very
Okay.
much, and thank
Yeah,
you
my
all
pleasure.
to participants. Okay, take care and
Yes,
goodbye.
thank you for attending. Okay, bye-bye.
Bye. Bye.